Afternoon, everyone. We've just gone live, so we might sort of brighten down a little, and we'll get the seminar going. So welcome to the Kirby Institute's World Hepatitis Day seminar. My name's Greg Dorr, and I head up the viral hepatitis clinical research program here, and I'll be chairing today's seminar. I'd firstly like to acknowledge the traditional owners, the custodians of the land on which we gather today, and pay my respects to elders past and present. We're meeting on the lands of the Bidjigal people, and I'd like to extend that respect to any Aboriginal and Torres Strait Islander people who are attending today either in person or online. So as I said, today is a seminar for World Hepatitis Day. So it's the week of World Hepatitis Day. The official day was yesterday. So July the 28th, for those who are unaware, is actually the birthday of Barack Bloomberg, who, which is interesting, we're focusing today on hepatitis B, and Dr. Bloomberg discovered hepatitis B in 1964. And there's an interesting link to Australia in that the hepatitis B infection was discovered by detection of the surface antigen of that virus. And that antigen was detected in an Australian Aboriginal person when he was investigating jaundice. So in fact, originally the antigen was called the Australia antigen, and it relates to the initial detection. He went on to develop a test for hepatitis B and a vaccine for hepatitis B, and was awarded the Nobel Prize in 1976. So made an enormous contribution to global hepatitis prevention and treatment. So that's why the World Hepatitis Day is held on the 28th of July every year. In fact, he would have been 100 today if he had have lived. He was born in 1925 and died in 2011. So just the format of today's seminar, we'll have three presentations from Behzad Hajari-Sadeh, Shane Tillakratner and Miriam Levy, and then we'll have a panel discussion which will be made up of Behzad and Miriam, and joined by Bianca Prain and Stephen Drew. So there will be plenty of time for Q&A. So that's why we wanted the seminar to be 90 minutes to give us that opportunity to have an interactive discussion after the presentations. So I'll start out by introducing Behzad, first presenter. And Behzad is an associate professor with our program here at the Kirby Institute. He's a clinical epidemiologist and NHMRC, emerging leader fellow, and he's done a lot of work in viral hepatitis over the last 10 to 15 years. So thanks very much, Behzad.
Thank you very much. I would like to start by acknowledging the traditional custodians of the land that we are gathering today, Bidjigal people from your nation, and pay my respects to elders past, present, and emerging. In the first presentation, I'm going to talk a little bit about the results of the REACH-B study, which is the national cohort study of the people with hepatitis B. Just starting with acknowledgements, REACH-B has been funded by the Department of Health. Gail Matthews is the chief investigator, Jess Carter is the study coordinator, and that's a kind of multi-center studies with many PIs from all of the studies that are contributing to the study. That you can see the names here. That's a long list. I cannot go through all of the names, but just to acknowledge that that was a kind of collaborative, very wide national collaborative study, and without the contribution of the partners, that would be not possible to do a study in this scale. Just a very quick background. About 220,000 people, they were living with hepatitis B in Australia. It is estimated that only 25% of them were engaged in any clinical care, and 13% they received treatment. That's very far from the WHO targets for Hep B elimination, which is 80% of the people who are eligible for treatment receiving treatment. I'll talk about the treatment eligibility in the next slide, but generally the kind of the representative data from Australia in terms of the care cascade of hepatitis B is limited. And that was one of the reasons that REACH-B was designed to fill this gap. I need to tell you a little bit about the hepatitis B treatment. That would be maybe boring for the people who already knew about that, but I think that's important to kind of define the context. The current hepatitis B treatment, antiviral treatments, they are very effective in terms of suppressing the virus, but that's not curative. Then most of the people who are receiving treatment, they are not curing the virus, but they are, the viral is suppressed and they can live a normal life with viral suppression. And given that the guidelines, the clinical guidelines recommend treatment for only in specific groups of patients, and that's mainly based on the available evidence to demonstrate if treatment is going to decrease the risk of liver cancer or cirrhosis or mortality. And because usually these are very long, longitudinal, expensive studies, sometimes there are not enough evidence for all of the groups of the patients. Then not all of the patients they are recommended for treatment, and the people who are not on treatment, they undergo monitoring, which is a kind of regular evaluation of the liver enzyme and the Hep B markers. But that's the guideline recommendation, which is a treatment indication, if I can say so. This is also called treatment eligibility. That's based on a kind of algorithm considering many factors. Some of the factors are clinical, like, for example, the viral factors, the liver function. Some of the factors, they are more individual factors, like age, the family history of the cancer, or advanced liver disease. Then that recommendation is coming from a very complex algorithm. Then firstly, when we talk about the treatment eligibility, this is a term that's used in the literature quite a lot, but that's more about the treatment indication or the clinical recommendations for treatment. And given this complexity, there is a very wide variation across the clinical guidelines about the treatment indication. This is just showing you a very a quick snapshot of what you can see in the clinical guidelines. Those on the purple, they are the Australian guidelines. One that's actually PBS indication. That's not a clinical guideline, but the GSI is the guideline developed by the Gastrointestinal Society of Australia. And the other ones, they are the different societies. For example, EASL, the first one on the left, that's European, WSLD, American, PASL, that's Asia Pacific, and WHO. Then you can see that's a very wide variation based on different criteria, and that's sometimes confusing for the clinicians. And just to add on the complexity, when they talk about the ALT elevation, different guidelines, they are talking about the different threshold for the ALT elevation. That makes the whole story even a little bit complicated. Based on this, in 2024, WHO developed a new guideline trying to simplify the treatment algorithm. Then, for example, they considered any patient with Hep B DNA over 2,000 as eligible for treatment if they have high ALT as well. But a couple of years before that, the Chinese Medical Association, and because China is one of the countries with a very high prevalence of Hep B, and they wanted to kind of broaden the treatment criteria, then they even make the criteria even broaden than WHO, and they identified any people with Hep B DNA detected, regardless of the level, they are eligible for treatment if ALT is increased. And WHO also considered other factors like liver fibrosis, even age, for example, in the Chinese guideline was considered as a treatment. Then they tried to first simplify the treatment horizon and also broaden the criteria to make more people eligible for treatment. For example, WHO is also recommending, if there is no access to Hep B DNA test, mainly in the low middle income countries, they recommended treating anyone with high ALT, regardless of the virus. Then this is important because now we need to know what is the impact of this changing the guideline, particularly from WHO. Chinese guideline is more kind of national, it is more suitable for the setting of the China, but WHO is a kind of more national audience, and that will be more implemented, hopefully. Then in this study, in the REACH-B, we wanted to, or in this analysis, we wanted to evaluate how these changing the recommendation will change the proportion of the people who are eligible for treatment. Just a quick overview of the study. REACH-B, as I said, a national observational cohort study of people with Hep B. There are 18 sites, clinical sites across the country in 6 jurisdictions. They are involved, and the data collection is based on the more kind of medical chart review. All of the clinical records which is available in the clinic will be reviewed, and the data will be collected. And also the data that I'm presenting is on the baseline, but the study is going to also collect the follow-up data as well. As I said, 18 sites. They are recruiting at the moment. 3,300 people they are recruited, and about 3,000 people they have at least one follow-up visit. Just looking at the baseline of the 4,362, I think this is the number that with the baseline data available. I think the number that I put in the previous slide was outdated. We have sites in 6 jurisdictions. Most of the sites are hospital-based clinics, 15 of them, although 5 of them, they have community outreach. Then we have representation of the primary care plus 2 primary care clinics, 1 justice health clinic, but still the majority of the sites are more referral sites, tertiary care-based sites. In terms of the baseline characteristics, 44% women, median age of 49, 28% they are First Nations people. About half the population, they are born in the East and Southeast Asia. That's something that we are expecting from the Hep B epidemic in Australia. And also 57%, they had most likely they had infection from mother or via family in terms of the horizontal between family transmission. In terms of the clinical data, the rest of the analysis is restricted to the people with enough clinical data for us to be able to do the analysis. And they are the people who had data on the Hep B DNA, ALT, and also defined Hep B clinical management, which is the number is 3,600. As you can see, 53%, about half the population, they had undetected or very low viral load. This could be because of the treatment, or even they are under monitoring, but still the viral load is very low. 58%, they had elevated ALT. This cutoff is based on the cutoff that GESA is recommending, and also the PBS, then kind of more Australian related. 14% e antigen positive, 7% cirrhosis. Hep D co-infection, just a very quick background for the people who don't know much about Hep D. Hepatitis D is a virus separate to hepatitis B, but also only coincide with hepatitis B. Then you see hepatitis D only as a co-infection or superinfection on the people with hepatitis B. And the people with hepatitis D co-infection, they are at the higher risk of liver fibrosis and cancer. Then although the prevalence is very low, it is important and it's recommended that all of the people with Hep B, they are tested for hepatitis D at least once. But the data shows that 64% of the population, they did not have test. Either they are not tested or there was not available record of the testing. This is probably something that can be considered as a gap in the clinical care of hepatitis B patients. Okay, in terms of the treatment or the clinical care of the patients, 46% they received treatment, 51% they were under monitoring. 46%, that's actually higher than what you are seeing in the general Hep B population. And this is more reflective of the nature of the REACH-B network, which is firstly, all of the people, they are already engaged in care. And also most of the sites, there are the referral centers, the hospital-based clinics. Then the estimation is about 22% of the people with Hep B, they are eligible for treatment. But having 46% on treatment, that's more reflective of the study setting than the actual population. And on the people, the majority of them, they are receiving entecavir. Of the people who receive treatment with tenofovir is the other more common treatment regimen. Okay, now if you look at the treatment eligibility, can you see my cursor? Oh, yeah. But this, the first two columns, they are the Australian criteria or guideline. Based on the PBS, 7% of the population who were not on treatment, they were still eligible for treatment. That's almost the same, about 8% based on the GESA guideline. And you can see that this proportion is changing based on the different guidelines. The highest proportion is seen if we consider the Chinese guideline. As you said, the indication of that guideline was to broaden the treatment criteria, which is actually based on that. The majority of the patients, they need treatment. But WHO also in a lesser extent, also their criteria increase the population who are eligible for treatment, more or less, probably less than double the size of what we are having based on the PBS criteria. Then based on the REACH-B data, the majority of the patients in the clinics that they are eligible for treatment, they are receiving treatment. That's a good sign. But there are still a small proportion, they are eligible, but they are not receiving treatment. Then we had a look at this, kind of stratified this data by the patient characteristics. First, we looked at the cirrhosis. As expected, the very large majority of the patients with cirrhosis, they receive treatment. Still 9% of those who are eligible for treatment, they did not receive it. It is important, kind of, because people with cirrhosis, they are at the more risk of HCC mortality, then they are a kind of a priority population for treatment. And these people, these 9%, that's still should be considered in terms of the care cascade. Looking at the HBe antigen, another marker which increased the risk of morbidity, mortality, 14% of the people with HBe antigen positive, they were eligible but not receiving treatment. And looking at the different characteristics of the more individual characteristics, the proportion between men and women, that's more or less the same. In the people with older population, again, at higher risk of morbidity, mortality, only 5% they did not receive treatment. That's a kind of a little bit larger in the younger population. Looking at the First Nation identity, that's also interesting to highlight. If you can see, regardless of the eligibility for treatment, less Aboriginal people, they were receiving treatment compared to the non-Aboriginal people. This is more reflective of the clinics that looking after the Aboriginal people in the REACH-B. And they are more from Northern Territory and North Queensland. And they are more, they have a very good coverage of the community care. Then the population that they are under care in these centers, they are kind of more representative of the general Hep B population. Then that's the reason that you are seeing less people under treatment, although the proportion who are eligible for treatment but not on treatment is a little bit higher than the non-indigenous population. Okay, just the last slide, conclusion. As I said, using the PBS treatment criteria, most of the people as a REACH-B participants, they will receive treatment. It should be noted, that's important, then the REACH-B study population, they are not representative of all of the hepatitis B population in Australia. Obviously, they are just the people who are already linked to care, firstly. And also the second is that still the hospital-based clinics, they are the majority of the clinical sites. Then that the data should be interpreted with that consideration. In terms of the small proportion who are not treated, it could be because of the ALT threshold lower than the female than the male, and also the limitation of the PBS criteria in identifying other factors which contributing to the high ALT. Probably this is something that we are going to discuss on the panel a little bit more. And the last thing is that given the high risk of fibrosis and HCC in the people with cirrhosis and e-antigen positive, we need to have a more focus on this population to make sure that all of the people who are eligible for treatment in these two populations, particularly, they are receiving treatment. I think that's it from me. Thank you.
Thanks very much, Behzad. If you've got questions relating to Behzad's presentation, hold them for the panel discussion, because we will be sort of addressing treatment eligibility within the panel. It's a great pleasure to introduce Shane Tillakaratne to give the second presentation. Shane was a PhD student of ours in the Viral Hepatitis Clinical Research Program, finished his PhD earlier this year and has taken up a position as a research associate. His PhD is largely based on data linkage work, and he's continued that sort of work, and he'll present some work specific to hepatitis B. So thanks very much, Shane.
Hi, everyone. My name is Shane, and I'm here to just take you through some of the work that we've been doing, looking at hepatitis B virus diagnosis and treatment in New South Wales. I'll be going through a background of Hep B-related morbidity and trends in late Hep B diagnosis and treatment, and also examining factors associated with late Hep B diagnosis and late Hep B treatment. So for those who don't clear the virus on their own, untreated hepatitis B can cause damage via fibrosis or scarring of the liver. This repeated scarring can cause increase the risk of cirrhosis or impaired function of the liver, and in turn, once if this seems to continue, it can increase the risk of decompensation, which is a severe dysfunction of the liver, which in turn increases the potential risk of developing HCC, or the primary liver cancer that arises from damaged liver cells. And both DC and HCC are primary or end-stage liver diseases that severely affect the morbidity and mortality among people with untreated Hep B. Across the globe, we've observed that there has been studies that demonstrate effective treatment can reduce liver-related morbidity and mortality among populations. Hep B infection can remain undiagnosed, and for those who are diagnosed, many can access timely care, and people living with Hep B can sometimes enter care after developing enter care after developing advanced liver disease complications, which definitely results in suboptimal treatment outcomes. And while antivirals are effective, even amongst those with advanced liver disease, delayed intervention can be too late to prevent severe morbidity and mortality. So on the topic of delayed intervention, we wanted to examine what are the trends and factors associated with Hep B diagnosis, late Hep B diagnosis and late Hep B treatment among people with Hep B and end-stage liver disease in New South Wales. To do this, we utilize data linkage, which simply put is the linking of records pertaining to an individual or set of individuals we looked at Hep B notifications, to which we linked to several data sets, death records, hospitalization records to ascertain indicators of DC and HCC. We also looked at alcohol use disorder indicators or history of, and also injecting drug use hospitalizations, which we paired with opioid agonist therapy dispensing records to define drug dependence or history of drug dependence. And to further characterize our cohort, we linked these records to Centrelink records to ascertain receipt of government assistance. And finally, we linked these records to the PBS to examine history of Hep B treatment. We included Hep B notifications between 1995 and the end of 2021, and ensured individuals were alive from 2010 and were diagnosed with end-stage liver disease. And our exclusion criteria were Hep B notifications prior to this 1995 due to early antibody assay quality, and post-mortem notifications were also excluded. I'll be going through a few definitions that we used in this analysis. Again, DC and HCC, we utilize hospitalizations to define DC and HCC, and we took the first hospitalization for DC and HCC as a proxy date for the date of diagnosis. And end-stage liver disease includes both DC or HCC. We also, on the topic of, on the definitions of late diagnosis and late Hep B treatment, we utilized a 2-year window, which was chosen on the basis that it provides potentially enough time to, generally prior to the onset of symptoms of DC and HCC, and in that time, diagnosis and treatment would be likely, we could likely see favorable treatment outcomes. So instead of reading this, I'll point you towards this figure to more explain the definitions. If we were to look at the blue point as a point in time where end-stage liver disease diagnosis were to happen, anything 2 years prior or after that point would be considered a late intervention or late Hep B or late Hep B diagnosis or treatment, and anything 2 years prior to that date would before that date would be considered earlier intervention or early Hep B diagnosis or early Hep B treatment. So for the overall cohort in New South Wales between 1995 and 2021, we found that 65,525 people were notified with Hep B. The median year of birth was 1967, majority male, and majority, large percentage of the cohort was East Asian born, followed by Australian born, and about 6% deceased by the end of follow-up, of which 1,672 were diagnosed with end-stage liver disease and were alive during the study period in question, which is between 2010 to 2021. And we now will look at late diagnosis proportions and treatment proportions, but we'll start with late diagnosis. And also we do have an extra year of PBS, so we're looking to the end of 2022 for treatment. So looking at Hep B diagnosis timeliness among people with end-stage liver disease, between 2010 to the 2021, we definitely see an increase. I will explain what the colors are. The blue is early diagnosis, and late diagnosis is split into 2 groups, gray being following the diagnosis of ESLD, and light blue is prior to the end-stage liver disease diagnosis. We can definitely see from the earlier period to the latter period, there's a definite increase, almost a halving of late diagnosis, and increasing early diagnosis among all the in all the periods. So that's definitely a positive sign. Definitely reflects improvements in clinical awareness and treatment of Hep B, earlier intervention of Hep B. Splitting the groups into DC and HCC, we definitely see the same sort of promising, encouraging trend of increasing early diagnosis and decreasing late diagnosis, and halving in both from the earlier to the latter period. We also looked at, there's a lot on this slide, but we looked at factors associated with late Hep B diagnosis among people with Hep B notification and end-stage liver disease. We utilized a logistic regression model. The factors we included were birth cohort, sex, Hep B notification, area was a proxy for residence of a person, country of birth, and histories of drug dependence, alcohol use disorder, or receipt of government assistance. And we defined recent and distant, recent history being as defined as observation within 2 years of end-stage liver disease diagnosis, and distant history as any observation occurring prior to this period. We didn't observe quite a lot, except we did notice that drug dependence we found had a high 1.75 higher odds of a late diagnosis, which is definitely an interesting finding. As we did examine monoinfection in this cohort, we're potentially possibly observing a selected population that may not be representative of the broader screening patterns among people who inject drugs in New South Wales. However, we will further look at this analysis and re-include the co-infected Hep C population to see if we still pick up this sort of finding. Also, we did find that the receipt of government assistance had a protective effect against late Hep B diagnosis, which definitely speaks to the benefits of support structures that facilitate treatment access and timely diagnosis, sorry. Moving on to treatment. Again, blue is early treatment and late treatment is in the light blue, and no treatment is in gray. Over the periods among people with Hep B and notification of end-stage liver disease, we do see an increase in early treatment and in decreasing no treatment proportions. However, overall a slight decrease in late treatment, but definitely quite substantial late treatment. While 80% in the final period in 2019 to 2022, almost 80% were treated, albeit half were treated late, but this is definitely an improvement to the earlier period where almost only 50% were treated. There is quite a difference if you have a look at the split between DC and HCC between the two periods. While we do see similar patterns over time, there are notable differences in treatment timeliness between the two groups. Key explanations may include DC patients more commonly to have having low or undetectable or low Hep B DNA or other liver comorbidities, potentially complicating treatment decisions. And while there is increasing clinical awareness that any detectable Hep B viral load in cirrhotic patients warrants treatment, however, our main limitation of this study, in our linkage, we lack Hep B. We lack clinical data, specifically Hep B viral load data. But overall, we do see a clear demonstration that there are clear healthcare improvements in Hep B care and for those with advanced liver disease in New South Wales. We also looked at factors associated with mistreatment opportunity among people with Hep B notification and end-stage liver disease. Mistreatment opportunity we defined as people who either had late or no treatment. So we also examined the same covariates, and we found recent drug dependence and alcohol use disorder. Both had a 2.2 and 2.6 higher odds of a mistreatment opportunity, which definitely speaks towards the further need for potential integration of care, perhaps in drug and alcohol settings. And also we did find rural or regional residents had a 2.5 higher odds of a mistreatment opportunity, which definitely points towards examining potential gaps in treatment access among people with Hep B and end-stage liver disease. And again, we do see the protective effect of receipt of government assistance, which again demonstrates clear healthcare improvements. Demonstrates the importance of social support systems that facilitate timely care. Overall, the findings, there's in New South Wales, we find declining late diagnosis among people with end-stage liver disease, and improvement treatment timeliness among people with end-stage liver disease. and the receipt of government assistance in facilitating early intervention, both diagnosis and treatment. There are challenges remaining. Late Hep B treatment, while declining, is still quite sizable in this cohort. Improving timely access, timely treatment access among people with drug dependence is definitely something to look at, and addressing modifiable risk factors, including alcohol use disorder, and in the embedding of Hep B care in drug and alcohol settings is definitely something we should further push towards. And also potential to investigate the care access gaps if there, as we've observed in those living in rural and regional areas. Thank you.
Thanks very much, Shane. Given Shane's not on the panel, we might take a few questions, but he's very keen to answer any questions that there may be related to his presentation.
Hi, Shane. Great presentation. One question, it might be just a struggle of mine given the stacked bar charts, but you're kind of highlighting that as the cohorts have advanced, the amount of people that are being diagnosed or treated earlier are more, right? And that's you're kind of referring to as a good thing, but on the converse, wouldn't it be a bad thing because you're diagnosing them earlier or treating them earlier, but they're still progressing to end-stage disease? It might be
True
that those numbers are getting smaller and it's just a function of the stacked bar charts, but
I would imagine even though this cohort is looking at the end result of what untreated Hep B can eventuate into, we are seeing overall healthcare it's sort of getting better over time, essentially, even though we're not even though these people ended up having end-stage liver disease, they ended up developing it, they ended up at least getting treated earlier, and this sort of trend is getting better, and majority of them being treated late.
But I mean, it's a good point because you think about the whole cohort of people with chronic Hep B, you're putting people on therapy and there's a bunch of them that are not progressing because of the therapy. So they're sort of removed from the equation, so to speak. So you end up with this somewhat selected population who develop end-stage liver disease. Maybe other factors are at play, et cetera, et cetera. So it is it's a tricky sort of analysis. But I think that given that there's still large numbers developing end-stage liver disease, the fact that there's a sort of reduced proportion that are diagnosed late is probably telling us that screening has improved, particularly in the older sort of age group. So I think that's a sort of positive message. Miriam.
Wow, I mean, it's a lot of data, and I've got like a couple of little just questions, but the first is to admit that maybe I missed it, but when you present lots of data as a percent of the total, whether we're happy or sad about it depends on whether the total's going up or down, and I wasn't sure if I missed it in the beginning, but maybe the rates were doubling every year of this outcome, the percent is not.
Neglect to put those in.
Yeah.
Yeah, they are. I thought I'd keep it simple, but yeah, no, definitely.
Is it going down?
It's going
down. Okay. So with regard to including HCC as one of the negative outcomes that you're trying to measure, our success with, when patients are adherent to antiviral therapy, they are much more likely to participate in HCC surveillance. And so you will cause a kind of lead time bias in your data and kind of, potentially create, it might look bad, but maybe they've all got a 1 centimetre HCC because they were in surveillance, which you can ablate, and that's not really, you wouldn't expect 2 years of antiviral therapy to change that outcome.
Yeah, that's fair.
Can you solve it though?
Yeah, but just on the numbers sort of point, I mean, they're going down, but the latter cohort's still a relatively large sort of denominator. So it hasn't reduced markedly. I mean, the risk of DC and HCC has come down from antiviral therapy, but they're
yeah. I mean, it's such interesting data, and you must do your head in at night. But like, if you're poor, the socioeconomic and needing government assistance, maybe you're less likely to afford red wine and expensive fatty foods and be obese. So your rates of, I mean, I'm just saying there's so many factors that you can't account for in that government assistance piece.
It's an early sort of covariate that I've used, but I have sort of broken it down a bit further, and I plan to use it in more analyses, especially this one. But just given the last minute sort of request to
Oh,
then-
no, you did amazing. You did amazing.
I was like over the week.
Shane came back from holidays last week and I said, look, you've got to give a presentation for the seminar.
Yeah, I know.
And I'm trying to say yes to things and not no.
No, you did great, and
Look
you made a story. But if we don't ask you questions, you go away and think that no one was interested.
Yeah. Yeah, I agree. It's a bit of a vague variable, but I'll definitely like sort of tease it out a bit further.
Thanks very much, Shane. Now I'd like to introduce Miriam Levy. I think most people will know Miriam. She's a hepatologist and gastroenterologist at Liverpool, staff specialist there. Been involved in viral hepatitis, clinical care and research for many years, and has had a particular focus on a couple of key areas, particularly HCC, prevention and care, but also antenatal hepatitis B. And it's been a pleasure to work with Miriam on the emergency department screening project search, and she'll be presenting some data specific to Hep B from that project. So thanks, Miriam.
Okay, thank you very much. I will try and not like, I'm just trying to analyze the data myself, and I'll try and ask you lots of questions to make sure you stay awake. And I did hear a University of New South Wales academic ask a colleague of mine to cut down their presentation from 40 to 10 minutes because 10 minutes is de rigueur now at the University of New South Wales. Otherwise people go to sleep. So I've tried. Is it true? I'll be watching at 10 minutes. This is the hepatitis B part of this story. You may have heard that we're searching for hepatitis in southwestern Sydney, screening emergency admissions at risk of chronic hepatitis. And this is the data from Search 3 extension, which is an extension as a sort of implementation test to see whether our enthusiasm and connections at Liverpool could be successfully applied more broadly outside of Liverpool Hospital, where I've worked for too many years. I want to acknowledge that Julia Di Girolamo is the senior scientist who actually, yay, has a tenured position at the Ingham Institute despite being in research now, and has led a lot of the operational and leadership elements of this project. And Benita was an advanced trainee in gastroenterology with us last year, and she's produced a lot of the graphs and analysis from this very much collaborative project. And it's been great. Yes, Greg has been a huge help in understanding the hepatitis C data we're generating, but he hasn't actually really seen the hepatitis B data yet. So it'll be interesting to see if he stays awake and asks any questions, stays off his email. I'll be watching. All right, as you know, hepatitis testing in Australia requires risk factor identification, lots of risk factors. And for hepatitis B, particularly if you're born overseas in high prevalence countries, and this is actually a Hep C slide where it may be dental procedures or operation, although most overseas born with hepatitis B, it's from mother and child transmission, and Indigenous have high risk factors. But Ben Cowie was a lead author in an editorial that analysed some data where he said, and I completely agree, current risk-based approach to testing where clinicians are expected to navigate a whole pile of risk factors is just needs to be transformed. And it is suggested that maybe one option is universal testing for hepatitis B rather than specific testing. Because if you do want clinicians to test for hepatitis B currently, then you need them to be enthusiastic, have enough time, know all the specific risk factors. You need patients to attend and engage. You need them to be willing to undergo risk-based questionnaires, offer truthful answers to potentially stigmatizing questions, and have enough health literacy for that conversation to happen in a timely manner, because you've got to remember most GP consultations are 7 minutes, and that includes the reason why they came. So why the emergency department? Well, it seems to be a high volume testing place where you could leverage existing resources, staff are there, Infrastructure's there, blood's already been collected for the clinical care visit. You've got access to marginalised populations like men who don't normally go to doctors and other marginalised populations apart from men. And we actually thought, look, you know, surely all these well-educated doctors are doing hepatitis screening in the emergency department anyway. That's where we started, and we looked at 500 ED presentations where there was an indication for testing, and 9 of them actually got a hepatitis test. Okay, so this is to share the data about an implementation of universal, not just overseas born or Indigenous, universal, automatic, and we used to use the term automated, but it's automatic because it happens automatically. Everything's automated in hospital laboratories. Hepatitis B testing in the emergency department. And with that information, we then will be able to glean some significant information about prevalence, which is a lot about today, and evaluate the cascade of care before they came and had this hepatitis B test, if they knew they had hepatitis B and whether they were in care, and to evaluate the linkage to care, because we always felt there's no point doing the tests unless we can find the people, tell them and do something about it. So this has been going for some time. Search 1 was a proof of concept, respecting at that time the fact that we should really only be testing hepatitis in overseas born, Aboriginal, or if there was a risk factor, but at least we could test the automatic part. This demographic information is available in the electronic record, and it was a legitimate group to test. And that was our original data of antibody for Hep C and surface antigen, which prompted us to go to Search 2, which EC Australia gave us some money to facilitate Julia's salary, among other things. And we were able to automate, instead of a human actually going through the record and working out who should have a test, to automatically trigger a test for hepatitis when you get a biochemistry sample in the laboratory. And we did some cost analysis, but costs are really interesting. We did actual cost analysis, i.e. how much the reagents cost, how much the machine, how much the humans involved, and the actual cost is cheap. The charges is a completely different conversation compared to the actual cost. But anyway, that's a different story. So for this Search 3X, we did 5 emergency departments, 5,000 per site. This is the Hep B data, but we tested both. And then we looked at all the data, which we're trying to do, as you can imagine. Patients had opportunity to look at multi-language information. Staff were educated in services, emails, etc. And we did it unbelievably. We're very grateful to Ministry of Health Support for the funding of Search 3X, as well as some additional small grants from Pharma. Bianca, thank you. Oh, it's changing. Okay, and so now I want to share the data. And in fact, it was estimated that Australia had 1% surface antigen prevalence, and in 24,790 tests, because sometimes there wasn't enough for surface antigen after the Hep C test. That's about the prevalence in universal adults in Australia. But obviously, if you break it down by risk factors, this is along the bottom, the prevalence depending on all Australian born, 18 out of 10,900, 0.2%. Aboriginal and Torres Strait Islander, 0.6. Australian born non-Indigenous, 0.1, and overseas born, 1.6. Unsurprising data, but it's useful information. And by age group. And this slide has 2 bits of information to save slides. It has the prevalence by decade. So this is age 40, and we're nearly 1.3% prevalence. The highest age group is age 50 to 59. But the second piece of information by colour is whether they knew or not about their hepatitis B, which sort of was a little bit about what we heard from Bezad, that it's very variable. But in green, these patients between 10 and, in this case, 0.4, that was the prevalence of people with Hep B who didn't even know they had it. and then it adds up. And I haven't presented it very, very easily, but you can get a sense that in light blue, the majority of people knew they had hepatitis B, but a significant proportion didn't. By country of birth, and there are 31 countries of birth who present to the emergency department, the prevalence we reported based on if there was at least 50 people in the denominator to make sense of the prevalence: Cambodia, Tonga, Vietnam, Malaysia, China. Now, those percent prevalences is useful for where you might look at doing community work, but you can also, I think there's another way of presenting it, that is, who is the most people? Like maybe there's only 50 people from Cambodia in the whole of Australia, in which case we want to put all our resources into Cambodia. So we do have that data as well. But anyway, this is a little bit about what we heard about how have people been looked after up to this point. And it's really quite difficult to present this in a way. I could just give you a table full of facts as if these columns make it easier. I don't know if they do, but we'll just go through them one by one. Who knew? And this is out of the percent, and the actual numbers is at the bottom. So of the 235 people where we could find the answer to who knew, 77% knew that they had Hep B. If they knew they had Hep B, did they see a doctor? 64% said that they did in the last month. And then we wanted to say, well, if they saw a doctor, did anything good happen with regard to their hepatitis B, particularly if HCC screening was indicated? It's not indicated in everyone. If it was indicated, did that happen? So first we had to kind of work out, of the cohort of 235, in whom was screening indicated. So it's age, gendered, family history. There are some elements, cirrhosis, that you have to kind of put into the metric. And of those who knew, these are who was indicated, and then this is, did it happen, right? So if we just look at who underwent surveillance for HCC screening the last 12 months when it was indicated, 149 it was indicated, only 40% actually underwent HCC surveillance. A bit complicated to go through where they knew. And was Hep B treatment indicated? And by our accounting, in 30% Hep B treatment was indicated. Were they receiving antiviral therapy? 85%. So I suppose that's the kind of big cascade of care data. And it's pretty good, but it's not perfect. And I think this is the biggest problem, the ones who didn't even know that search might have a role to address. We characterise the Hep B patients. That may not necessarily be of great interest, but amazingly, it's very similar to the data that Behzad presented, come at it from a very different way. So this is very granular data. It's very detailed, but like as I was watching, I saw it was about the same. With some variation, because that was a hospital clinic, which is enriched with certain patients, but 5% e antigen positive, 14% with viral loads above 2,000, a bit of co-infection where we could identify with Delta, and similar rates of cirrhosis, similar rates of on treatment. So this is the viremia, similar in the way if you divide up the levels of virus, depending on whether you're in China or the PBS, and what you believe the indications for treatment are and whether they'll change over time. But if you want to say greater than 2,000, might be just an indication for treatment as clinically significant viremia. It varies a lot by the age group. It's somewhere around between 25 and 5%. This is excluding in green the ones already treated, obviously. And then there's a whole big bunch of patients who on that single test, their virus levels were less than 2,000. But there is clinical, it does fluctuate a bit in individual patients. And so I look forward to a day when all viremic patients are treated so we can stop trying to fuss about all the fluctuations. And then there are some who are undetectable, and that's spontaneously undetectable, which we know exists. And then I don't find this analysis terribly helpful, so I'll just explain it. If you look at the 25,000 people we tested, were there things in the Hep B patients that could point to you specifically testing only a subgroup? So, for example, if their age was very different, but their age is, they're a little bit older with Hep B than the overall cohort, they're a little bit more likely to be male than the overall cohort. But of course, much more likely to be overseas born, but 55% of our of our cohort are overseas born in southwestern Sydney. Overall, and I'll be finished soon, I just wanted to tell you the key findings. I think prevalence 1%, but much higher amongst overseas born individuals, where we really need to be doing some better surveillance. Highest in Southeast Asian born, with in some populations nearly 10%. I think 20% were newly diagnosed, 28% receiving antiviral therapy, 60% had detectable viremia. That's a lot of people that we maybe would choose to treat. I don't know what the maths on the cost is. The drug's very cheap. The drug is so much cheaper than doing an HBV DNA, just by the way, which is interesting when you want to start to do maths. Co-infection in maybe 4.5%, but this is an antibody test. Not all of those will be viremic. And I think we can see that there are big gaps in care for poor primary care doctors who are just not able to stay on top without a registry or without some kind of help of HCC screening, with only 40% having HCC screening where it's indicated. Limitations, well, it's not the upper North Shore or the lower North Shore. I don't even know which is which, but maybe one of those doesn't have the same rates of overseas born, and maybe it wouldn't be as relevant to do screening for hepatitis B. And maybe with higher literacy, patients will present themselves for treatment from testing. The cost is a real consideration because pathology charges are site dependent, and the pathology companies are able to charge a huge amount for laboratory tests, which really, really inform whether this is a cost-effective strategy. Project officers are going to be essential for these kind of linkage to care screening pathways. And it's really not a sustainable model if there's not dedicated staff. And Hep B, Hep C, it's much more justifiable because Hep C has like 8 weeks of treatment and you're done, you're cured, goodbye. Hep B is a lifelong journey, so you need to be confident that that journey will be executed well. It's no good doing tests if there's not care that follows. It's a big team. It's a big steering committee of people who've thought about whether this was a valid approach, and lots of site-specific groups who've engaged and been committed to find out if this was useful, and governance. And yeah, so it's a big project. Thanks a lot for listening and staying awake.
Thanks very much, Miriam. We might get Miriam and Bayzad to come up and join the panel. And I'd also like to introduce Bianca Prain, who's the Director of Public Health Programs at the Centre for Population Health, and Stephen Drew, who's the Chief Executive Officer for Hepatitis New South Wales, to join the panel. And both of them have considerable experience in the sector, so it's great to get their perspectives along with Bayzad and Miriam. While people are getting settled, I'll just ask Miriam a question about the SEARCH study. I know I'm sort of a bit conflicted being involved, but in terms of the surface antigen prevalence, you said it seems to be about the ballpark for Australia, but you would have expected southwestern Sydney to have a higher sort of prevalence than an average. So were you somewhat surprised that it only came in at 1.0 rather than a higher level?
Yeah, you're right, Greg. And in SEARCH 1, it was actually 2%, but that was overseas born. So I suppose I had no idea that half of our ED presentations were overseas born. I mean, it's incredible. What a country. So I suppose if I'd thought it through and thought about the maths and I knew that fact, then it would have been obvious that it was 1%. But I don't know. I didn't really think about it enough. I just did it.
But also not not just what a country, what an area of Sydney, because Sydney, southwestern Sydney is clearly much more sort of multiracial and diverse than many parts of Sydney or Australia indeed. So,
and I think even though around North Shore, and I joke about North Shore, but I think if you migrate from places that are maybe Southeast Asia, but had the vaccination for a lot longer than people from developing countries. So it's not just being overseas born, of course, it's being overseas born and more likely to be from a developing country where vaccines weren't necessarily provided.
I've got a few planned questions for the panel, but we'll take questions from the floor. And as usual, we'll hear a question from Professor Grebley. Thanks, Jason.
Thanks. No, but it was just following on from that, because I'm curious, Miriam and whoever else wants to comment, do you think that means that we perhaps might be overestimating the population prevalence of hepatitis B, given what you're seeing in a population that you'd expect a somewhat higher prevalence, but I think at a national level? I don't know if you have any thoughts.
I don't know. What are the demographics of a national level? What proportion of us are born overseas? I suppose you're right. The maths should be able to be done with that inputs, but I don't know what the inputs are.
Look, I think one of the issues that people forget about, or maybe they don't forget, but they don't sort of consider within this, that obviously our prevalence of chronic hepatitis B is very much affected by our immigration sort of inflows. But most of Asia started universal infant vaccination from the early 2000s. So there shouldn't be many people under the age of sort of 25 or 20 that have chronic hepatitis B coming in with their parents, for example. So that has changed over the last sort of 2 decades, clearly. So maybe that's a factor that's bringing the prevalence down a bit. We're not getting much new infection generation within the Australian sort of context. It's mainly people coming in with chronic hepatitis B are adding to the pool. And obviously a lot of people are dying, they're getting older, and they come out of the sort of chronic hep B sort of population. So it sort of, I think that's why studies like SEARCH are so sort of pivotal, because they give us really good sort of prevalence estimates. And I think even more importantly, the cascade of care element is really interesting. I mean, I was encouraged, it's the first time I've seen this full sort of Hep B data set, by the proportion that knew of their diagnosis, 75%. So that undiagnosed 25% is actually less than what the sort of broader Australian sort of modelling has put up, which is sort of at least 30%. And the proportion of people that were diagnosed who were eligible for therapy that were on antiviral therapy, 85%, I think it was. So, that's pretty encouraging to me. Okay, there's some gaps in HCC screening. A lot of us are hopeless at sort of ordering HCC screening appropriately. But the engagement in care, even that was a lot higher than some of the estimates, which have said only 25% of people with chronic Hep B are engaged in care. So one of my questions for the panel comes back to that engagement in care piece, and the sort of modelling work and some of the sort of looking at the MBS items for Hep B viral load has suggested that only 25% of people are in regular care. So the monitoring group should get annual viral load at least and some liver function tests. Is that a true estimate, that 25% of people, or is it a problem with the methodology for estimating engagement in care, and how should we go about trying to improve that methodology and how we characterise who's engaged in care?
Can I just, before the broader audience respond, say that when we have meetings with Greg on Hep C, we do learn how to present the data more clearly, because it's not my expertise, and we had to decide how to categorize people. So how do you decide these 250 people who say, yes, they know they have Hep B, and yes, they go to the doctor every year for their Hep B? We can't tell if they have an HPV DNA test, and we didn't chase that up. So that's a problem with our data, and before it gets written down in stone, it might be worth thinking that this is a workshop, and it's interesting to think about the implications, but yeah.
Yep. So for the other panel members, what do we think about engagement in care? How do we best categorise that? If it's truly, a pretty low sort of estimated portion, how do we sort of leverage an improvement in that, I suppose, is a broad question.
I think the issue that needs to be considered is people's understanding and health literacy. And I take the point that we've got some great data, but they are very clinically based. They're going through centres that people can get access to, and they may have been doing that for a number of years. So there is a history of connectedness. We talk to community and people don't know their status. You ask if they've been to see a GP about their Hep B, and they'll say yes, but what they actually mean is that they've been to the GP. They haven't necessarily been to talk to them about their Hep B. They've been because they were told to go and see the GP. So I think we need to be somewhat careful about that and understanding. We are talking about communities that English is not necessarily their first language, and their understanding issues, cultural issues around ownership and acknowledgement of it, are going to impact about how they engage with services, and particularly GP services, and what information they can effectively share. We have always been very strong when we're doing some great stuff with the Kirby now with our liver care program, but we've been very clear that when we want to enroll people in those programs to collect data, that the consent and the data collection information is available in language. And it has to be a critical thing. I think there is work to be done around that to make sure that we are getting the questions right and people understand them.
Just on your question about using the PBS and MBS data, I totally agree. That's MBS data has that 25%. That would be probably the minimum, because as you said, there are many patients that they are tested outside the Medicare billing system, which is even looking at the data, we see many patients, then they started treatment without any record of viral load testing. That's very clear indication of probably they were tested outside of the Medicare billing system. As a kind of methodology suggestion, I think still using that administrative data would be very useful, but we need to come up with some sort of adjustment using some data, like for example, SearchC, which is based on the survey, the data from patients. This is a tricky point, that how to adjust that and coming with an adjustment factor.
Bianca.
Yeah, I was going to ask, Bezed, at a national meeting last week, South Australia presented the difference between the Medicare data and SA pathologies data, and there was quite a big difference. And I was asking the team earlier today, what do you think that would be for New South Wales with testing starting or treatment starting in a non-Medicare outpatient setting in New South Wales? What do you think the percentages or the numbers we're looking at? They were looking at about, I think, 1,000. They said the thousands in New South Wales. Do you think that would be as much or more?
Probably cannot give, no, for the treatment, I think PBS data is accurate enough. I don't think there are many treatment outside PBS, but testing is more important, I think. But I don't know. I don't have any kind of estimate off the top of my head.
I think it could vary enormously from jurisdiction to jurisdiction, because it's all about how specific services are funded in terms of their pathology sort of components. And a lot of services rebate through MBS, but we know that prisons and some sort of community clinics get sort of block funding in terms of their pathology services, so they're not Medicare sort of rebatable. So we're going to try in New South Wales to explore this. Just Annabelle's nodding. It's very important for Hep C, and it's also important for hepatitis B to try and to fill in the picture in terms of who's getting Hep B and Hep C sort of viral load testing. Because I think if we just go on the linked MBS data, we're absolutely missing a huge number of people. Now, what proportion is that? We don't know, but we need to try and get a bit more clarity on this issue, because I think it's good to say that there's huge gaps in engagement and care, but we have to have a reasonable estimate of what that gap is and who those people are. And if you don't have all the data, you can't properly evaluate what are the subpopulations that are really sort of missing out in terms of that engagement and care. The next sort of issue I wanted to sort of address is, and Miriam brought this up at the start of her presentation, is the issue of universal sort of testing. So Search identified 25% underdiagnosed, maybe a bit smaller than what some of the other estimates are, but it's still a significant proportion of people that are unaware of their diagnosis. So the question is, should we move to universal testing? What would the coverage of that universal testing be likely to be? Because it's one thing to say everyone should be screened, but it's another thing to actually get that implemented. And what are the sort of cost effectiveness and the cost implications of universal sort of testing?
So that's the interesting thing, to say universal unless you have an implementation plan. And that's why Search was universal automatic, not just universal. And I think you're right, Greg. Look at bowel cancer screening. I mean, until you've got a registry and you actually send out. Now, in areas of low health literacy where I work, there's only 30% participation in national bowel cancer screening. So there's still going to be issues, even if it is a mail out. But I feel our data actually for hepatitis B supports a tailored screening to overseas born if you want to be cost effective about it. But how you operationalize that, I don't know. But gee, I think if we just treated viremic patients, word would get out. Because it's so complicated. Like, you're measuring the HBV DNA
Sure.
as a test to decide if your care's good, but no one quite knows what to do with that information, and maybe GPs aren't that convinced if the liver tests are normal that you'll do anything with it based on the PBS guidelines. So I think actually the mess is encouraging poor adherence by primary care in the in the care.
But linking back to Search, it would be interesting to sort of estimate, for example, what proportion of the population, and more specifically, what proportion of the estimated Hep B population would go to emergency over a 3 or 4 year period. And I would imagine it's the majority. Now, is it the large majority? If you had a universal screening through emergency departments, would that be much easier to implement than through GPs who have to remember a whole bunch of things they're supposed to be screening for, et cetera, et cetera? So there are a few different models I think you could sort of evaluate to see what would be the best, inverted commas, universal screening approach to take forward. Basically.
Yeah, I think one point to be considered for the universal testing is the original idea coming from United States, but many people, they don't just note that there are much difference in terms of the setting when we have in Australia rather than US. For example, based on the modeling data, as you mentioned, about estimated 70-something% of the people with Hep B that have been diagnosed. Then this universal screening is going to find that 25%. But on the other hand, we see the major gap after diagnosis in terms of the linkage to care, maintaining care, HCC screening, for example, as Miriam mentioned. To me, if we want to invest in something, those parts, they are much more important than the universal screening, which is very different from a setting like US, when the diagnosis, the proportion who are diagnosed is way lower than Australia.
And if you think, if it's a 1% prevalence and you've got a quarter of those undiagnosed, that's only 2 or 3 people every 1,000 people that are screened in a universal program. So it's a lot of screening to find a couple of people in each sort of 1,000 screen. Now, there's obviously cost effectiveness that can be sort of run across those sort of scenarios, but we have to be realistic about how big a program this would need to be to find the undiagnosed sort of proportion.
And just on that, universal screening comes up at every BBV and STI panel that I sit on. And there's quite conflicting opinions in certain streams of the stigma and discrimination associated with universal screening, ensuring the patient or the person is connected into appropriate cultural care. cost effectiveness aside. So I'm always intrigued the different from HIV to Hep C to Hep B, the different opinions and the strong voices that can come out for or against it. So I do think when we look at universal screening, I think there's more to think about and making sure that people are at the centre and our systems are there to support. In the GPs, that would be great, but none of the systems talk to one another. At the moment, if single digital patient record gets off and running in 2028, 30, we may then have a system which would enable that kind of patient-centred history to move forward. But I think until we have those systems in place, it would be a really hit and miss way to go unless implemented correctly.
Jason.
So just drawing on the sort of, what Search achieved has been fantastic in thinking about this sort of targeted approach and thinking about like a different setting and moving slightly outside the universal testing. I'm just curious to hear your guys' thoughts around sort of antenatal testing. How well are we doing around Hep B? Greg mentioned that maybe this is one of your areas of interest, Miriam, but even any of the other panels as well. And what opportunities might exist around Hep B and that setting?
Well, firstly, antenatal testing for universal testing of pregnant women with the interests of baby at heart was never an issue for stigmatized. Heaven forbid we stigmatize people, heaven forbid all sorts of things. That has it's been standard of care for 30 years, and it's no big deal, and it's done well, and I think it's done extremely well, and I think the rates when Ministry have spent some effort to try and investigate the proportion of pregnant women with Hep B who then have high viral load as well and receive antiviral therapy is also done, and the babies get HBIG, all of that immune prophylaxis therapy plus antiviral therapy for high viral load mums, I think is actually done extremely well. But it's a case in point of where there was never any pushback about universal testing. And so I just felt like, I don't know why it's different for the general population. And although I think stigma is bad, I do think that there are risks and benefits with putting stigma ahead of clinical care. And actually, all the patients have been incredibly grateful through Search. We have to remember that in Australia, we've got an incredible health system, and the reasons why stigma exists in other countries are not necessarily as relevant here. And with education, they can become aware of, the health opportunities of a diagnosis. So yeah, it's a complex area, I take it, but yeah, I didn't answer your question. I just waffled. Does anyone else? Does anyone else want to remind me or answer his question or raise anything? You guys, you've all been so good.
I think you answered it. We're doing really well.
Yeah, I think we are.
And we are. I think just to pick up on your point though, Miriam, the issue around stigma and discrimination is one that is much more culturally based. What you were talking about there, and it is a fantastic result, is that the Hep B testing and antenatal care is just part of a whole of person experience around health. We haven't necessarily been doing that within communities. We're talking about a disease-specific thing. In a lot of Asian communities, if you aren't already married, there is a fear about what does that mean for your chances to get married? What does that mean for your family or your desire for family? I think the lesson that we can learn from that is we do make Hep B part of a broader liver or a normalised health process rather than putting it out front and centre. And certainly that's the feedback that we get from our communities that we engage with. And we also hear it through other forums, through community leaders. Having said that, it isn't, your point is very valid. It's also not consistent amongst those because they're not homogenous communities, and the experiences that they bring with them are their experiences from their other countries. And so it isn't that easy, unfortunately. I have a great deal of sympathy for universal testing because it is an opportunity to normalise it. And say, liver care, we test for Hep C, Hep B, and do a FibroScan. We're doing a liver thing, and it has demonstrated its accessibility and acceptability within a wide range of communities, from the Pacifica community to Asian communities.
In the last sort of 5 minutes, let's move on to the other big question around Hep B, which is the treatment eligibility. And Bayes sort of clearly showed that things change enormously according to different sort of guidelines. If we were to adopt the Chinese Medical Association guidelines, the large majority of people with chronic hepatitis B would be eligible based on age above 30 and detectable virus. So I suppose in that context, and acknowledging that there is a diversity of views, but say they developed a consensus to broaden the treatment eligibility considerably, how would we move forward with that? How would we apply to PBAC to have that taken up? How would we build a case behind that? And would that be the answer to the engagement and care sort of gap by making a much higher proportion of people treatment eligible? So look, there's a few sub-questions in that, so I'll get the panel members to address that.
Well, yeah, I mean, you did such a good presentation summarising all the poor GPs. How on earth do they cope? How on earth do they know what to do? But have you costed out, or is there a cost consideration that underlies these expert societies and their decision making? Because, as I said to you, there is an example, ridiculous long tables that tell you whether or not you should use antiviral therapy in the setting of immune suppression, right? And so we as clinicians, you look through these complex tables, and then they say, if you choose not to use antiviral therapy, you should monitor HPV DNA 4 times a year. That is more expensive. And that's just the cost of the lab, let alone the visit, the doctor's time, the patient taking a day off work, ridiculous compared to how cheap antiviral therapy is. So I feel like when you put up those tables, I'd like you to tell us a cost justification for the Chinese model, which would make, I think, clinicians a lot simpler. I wondered if you have a comment.
That's a very important, interesting point. Cost effect or any kind of economic analysis has to be a part of any kind of recommendations. And for example, the WHO guideline, they claimed that they did the cost effectiveness analysis. But to me, I'm not a health economist, but to me, that should be dependent on the country, on the setting, on the different economic classification. Then I cannot understand how, for example, WHO as a global institute can do cost effectiveness analysis and apply that to a kind of global recommendation. This is something that I don't know. Maybe there are some ways that beyond my knowledge, but definitely needs to be supported by the economic evaluation. I think the professional societies, for example, GESA or the Infectious Disease Association, they need to probably just see if they wanted to update the Australian guideline based on the new WHO recommendation. That's, I think, kind of needs expert opinion or experts getting back together. And even if they do, I think from that to implement those criteria to PBS, that's not an easy way, because that's PBS is something that clinicians, they are obliged to follow. Even, for example, the clinical guidelines say something. If it is not under PBS, the clinicians will be get audited. If they do something, then this is a kind of a pathway that I think that's not as easy that we think.
I think there's probably a little bit of leakage outside of PBS criteria that's happening at the moment, but I get your point that that they are guidelines in terms of reimbursement, and you're supposed to adhere to them. I think around the cost implications, I think simply put, some people are saying that generic antiviral therapy prices come down enormously in the last sort of decade. It's relatively cheap, particularly in settings like China and other generic producers. Viral load testing is still a significant sort of cost. Maybe you don't even need to have ongoing monitoring of viral load when you're on treatment. As long as you're taking the therapy, you're going to virally suppressed. If you're not on treatment, we've got to monitor your viral load over time. So let's just put everyone on treatment as long as they take their treatment, they should be fine. So that's a very simplistic way of looking at it. But I think there's some of the issues that are coming into play. I'm not saying I agree with it, but in terms of developing sort of support for this sort of broadened treatment eligibility. One of the issues, though, is that when the new therapies come along, you'll have all these people on antiviral therapy. A lot of them never needed it, and you'll have to then potentially offer all those people these new curative therapies. Are going to be very expensive. You're going to have a lot more side effects than the current sort of therapy. So the landscape's going to change, and the cost implications of funding these new therapies are going to be enormous, at least in the early sort of years. So it's complex. It's a space that's going to change enormously over the next sort of several years. So it'll be interesting to see how it all pans out. Any other thoughts from the other panel members?
Just one last one. We had Ben Cowie presented to the National Beavers group last week on co-listing Hep B medications as S85 and S100, and pushed pretty hard for the Commonwealth to make some accountability seen. They've pushed this for the last 10 years and haven't got anywhere. The Commonwealth took that on note legitimately, I believe, and we're going to walk away and have a chat to PBS to see. They had a perception that if it was an S85, the cost would significantly increase for the consumer. Ben told them quite abruptly that that is not true. So they were going to work together to move forward to see if we can have a co-listing for the Hep B medications in New South Wales, with the co-listing to decrease those barriers also. So I do feel that there was a little bit of success made in that meeting. So hopefully we'll see something there too.
I was just going to comment, Greg, that in terms of your analysis, I think it's very, very true. The issue about changes coming through is very real. But then what's the opportunity cost otherwise, and how many people are saved, and what are the dollars saved in the lead up to those changes in the introduction of curative costs? So unfortunately, governments are very much focused on the here and now, and they're not particularly interested in return on investment, for want of a better term. But I think that is an argument that needs to be made, and it needs to be continually made, because if you are treating people, if you're reducing transmission in the meantime, those are very legitimate cost savings that are achieved to the government, that a case can be made for, and there's always swings and roundabouts.
Although it's a little bit different to Hep C in terms of the treatments prevention. We've got a pretty effective Hep B vaccine. So it does make that sort of treatment for prevention sort of scenario, other than a bit in the mother-child sort of like context, less of an issue, I think.
Yep. Yeah. Which maybe suggests that the issue is there's a big campaign that's needed around people finding out or knowing their vaccination status. And then maybe the campaign is those who haven't been vaccinated get vaccinated, and there is a very much subsidized vaccination campaign. So I think we can look at just one part of the equation, or we can look at the preventative stuff more holistically as well.
We've gone a few minutes over time. Apologies to a couple of questions online for not getting to those, but really like to thank all our presenters and panel members for what's been a great seminar, and thanks for everyone coming.